This is just about like a phakic base excision, how we can go about it, just tips of the surgery. Very often we come across young patients post-trauma with giant retinal tear. Can you play the video? Giant retinal tear. So while it is easier to go ahead and do the vitrectomy from inside, the color is not coming up properly. We have a mental block when it comes to tackling the vitreous base. You can see here. So this is a phakic patient, and if you see here in the lower part, here you can see because there's a little bit of dialysis, but you can depress and go up to the ora and remove the anterior flap without fear of touching the lens if you do it properly. The tips are you can use a bud, but the thing is it's got a rough surface. So the direction of push is into the sulcus and inside, pushing it towards. So you can see you can go right across also. And the age of the patient is particularly important. The young patient, you don't get to touch the lens. If it's a little older patient with a thicker lens, then you tend to touch the lens. There is another young patient who had inferior PVR and somewhat of exudation as well. So you can see there is contracted retina here. I thought I can peel the membrane and go ahead, but it was not possible. It was a fibrovascular proliferation here, and the break was somewhere out there. So extreme degree of depression, and you can remove this anterior flap quite easily. And the break is somewhere within that's the HST. The risks are if you are too aggressive, we may be creating a zonal dialysis, in which case you will have air coming into the anterior chamber and subsequently silicon oil. But if you're careful, you can avoid it. So here I'm using a muzzle hook to depress. I think we're going back to the older video. I don't know why. This is the first video actually. Somewhere here. No, they both are in the same video. That was the second case just playing actually. That is the first case actually. Another key points are that make sure that the sclerotomy is a plug, because sudden change in the hypotony, sudden change in the intraocular pressure can give rise to slippage of the instrument and result in touching of the lens. Now we are going back and forth. Yeah, we're going back to the same first case. I think we can stop and then somebody else can present. Yeah, that's the one, yes. So can you go a little bit back? So this again is a phakic patient. So can you drag this away? This one. Drag it away. No, drag that bar away from the. It's okay, leave it alone. So you can see right up to the ora you can go. And this is a fibrovascular proliferation. Actually, there's a little bit of vascular anterior proliferation. You can see that's the anterior proliferation. You can see that is a neovascular proliferation which is there. And make sure that the plug is in place or the valve cannula is working. Otherwise, sudden change in the pressure, it's a kind of a play between how much you depress with your other hand and how much you are accessing here versus the fluid going out through other routes. So you can do a retinectomy as well. So that's a break which is out there. So this fibrous tissue which is arising going up to the ciliary body can be dissected, and you can see the lens is still remaining clear. And once you have done the cautery, some amount of the air bubbles are sticking to the posterior capsule. So you can see here, which gives us a clue where the posterior capsule is. This cannot be attempted in all patients, but like younger patients you can. And as I mentioned, the key is make sure the globe is formed and we do the depression ourselves. because like when the assistant depresses, you don't know how much they are pressing versus how much you are going to use vacuum. There can be sudden collapse of the globe, and use a bud. This is an okay instrument, but using a bud actually gives some amount of more friction. So a little controlled controlled depression is what you can get. And both these patients, yes, like there was no zonal dialysis, we could go ahead with a fluid air exchange, and the air did not come into the antechamber, but that's one thing which we should be very off. So you can go ahead and peel as well. You can see go right up to the cannula without even touching the lens. You can go 180 degrees, still not touch the lens, and you can see even the ciliary body region, you can see there's fibrous tissue coming close to the anterior part of the infusion cannula, we can still touch it. So just to show the finer aspects of how you can do a phakic base excision. If there are any comments, I'd be happy to. So any thoughts, sir? Any comments? Mic is there next to on the other tables.
It was very elegantly shown how you can save the lenses in many cases where hitherto you are sacrificing the lenses. I think you can use it this way where the microscope light is used to see the periphery, but you can also use bimanual with the chandelier inside the eye, wherein also you can probably go all the way to the periphery and not damage the lens.
I have not done it, but Dr. Natarajan keeps showing that turned, bent cutters.
Cutter.
Does that? I've never tried to bend my cutter, I'm afraid.
It was only in the 20 gauge.
No, so has anybody done with 23? I was just wanting to do a few days back, but I thought I'll manage without it. If I don't, I'll do it. But it worked without it also.
Probe won't enter in MIBS.
No, entry is not an issue. Entry is not an issue.
It would have become less curved because of the
No, entry is not an issue.
Yeah, I have not done it, but like I find this quite easy to do it,
Yeah.
not a problem.
I'm saying in addition to what you're doing with this.
Yes. I don't know, because we can like bend the light pipe, whether we can bend the cutter by using a 20 gauge, 50 cc syringe over which we bend and see. I have to bend it and see if it still works. I think I did it once, it did work. The cutter does work if you bend it gently over a 50 cc syringe, it still works. But may not be for multiple cases, but I think I did it once probably.
I'll request